Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to Ms. Jennifer Verma, Senior Director, Collaboration for Innovation and Improvement at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Verma.
Hi guys, sorry about that. We're just getting started a little bit late here, but we're pleased to welcome you to what is our 7th content webinar as part of the Inspired Approaches to COPD Creating Value Collaborative. I'll roll right into what our objectives are for today. We're really hoping that today can be quite interactive, and we're pleased that we have a number of teams that are participating and weighing in on what they've learned so far through the course of this collaborative. But specifically, we're going to focus on your sharing of strategies that you're using to sustain your effort. So this really relates to that formation of a business case, some of your sustainability planning that you've already got underway. Identifying what has been some of the important facilitators and mitigating strategies that you found is really helping to further your progress. And then the third part of today's webinar, we're going to focus on some of your initial thinking on moving to scale, and we want to make that conversation around scale quite practical and pragmatic in terms of what it means relevantly for you in your context. So today we're joined by a number of faculty. We've got Graham Rocker, of course, Medical Director of Inspired in Halifax. Kathy Simpson, I believe, is also calling in from Halifax, spiritual care provider, and has Jillian Demmons, who you all know, Coordinator Evaluator of Inspired, with her as well. We've got Sean Morrison, who's the Director of the Lillian and Benjamin Hertzberg Palliative Care Institute and the National Palliative Care Research Center, joining us once again. And I believe we have most all the teams on today's call and perhaps a couple of other faculty. Specifically, the teams who've agreed to share some of their learning, although, like I said, I'm encouraging all the teams to really weigh in on these conversations throughout the course of the webinar. But we're going to hear specifically from Carolyn McPhail, and Carolyn's the Chronic Disease Prevention and Management Manager at Health PEI. And she's also got Kenny Martin, who's the manager, I believe, of cardiorespiratory care at Health PEI with her there in PEI. Wendy Laframboise is the nurse practitioner. We've got Sherry Dagg, the clinical manager at the Rehab Center at the Ottawa Hospital, as well as we've got Carol Schaap, the chronic disease specialist, chronic disease collaborative at the Winnipeg Regional Health Authority, joined by Craig Hillier as well, a regional manager, respiratory therapy and acute care. And then Rick Steeney, the manager of chronic disease management at the Saskatoon Health Region. So like I said, in addition to our folks who agreed to participate and share some of their learnings on today's call, we'd love to hear from you as well. So we're going to roll right in actually to our first set of questions. So have some thinking around this. So part 1, sustainability business case planning. We're interested in hearing what have been the most compelling lessons and impacts, recognizing that it's really early on, we get that, but from your Inspired work so far, and how you're communicating those milestones or those important lessons with your team, with your senior management, with your community, because so much of what we've been talking about has been about stakeholder engagement and how important that is in sustaining your efforts. So with that, we're actually going to go straight to our teams, and I think we'll start here from east to west. So I'll come to Carolyn and Kenny first, and then we'll cycle through our other presenters, but I'd encourage our teams that are online to also weigh in, and you can certainly, we'll get to a portion where you can press *1 and enter into the conversation verbally as well. So first to Health PEI's Carolyn and Kenny, your thoughts on these questions.
Thank you. So the first question around lessons learned and impacts from the Inspired work so far. I guess one of the first lessons was to be very clear on the eligibility criteria. So to date, we've had 31 referrals that have met the eligibility criteria, but we also did have some extra referrals that didn't meet because the staff didn't understand what we meant by community dwelling, so we had to go back and clarify that. And otherwise, things have been going along very well. We've had a few people who declined, but for for the most part, feedback from patients and staff and families has all been very positive. From the hopes and expectations questionnaire, some of the comments are, comfort knowing somebody is following up, learning about their disease, improved quality of life. So we know we're all on the right track here. Some of the patients are already known by our primary care nurses. However, another big positive that's occurred is that we have a COPD program with the primary care nurses, and so we're getting better uptake in that program and connecting to that, and further refining of our COPD program in primary care. And word is spreading. We recently received a call from one of the private home care oxygen companies where clients are starting to hear about the program and want to join. So, and although they may not meet the eligibility criteria for our INSPIRED program, we are connecting them with our COPD program in primary care as well as our integrated palliative care program. So getting some of those great connections. Do you want me to go on to question number 2?
We'll pause. We're gonna try to work through parts 1, 2, and 3 separately. So anything else on sort of business case or making that business case or things that are helping and sustaining and furthering your efforts?
Well, we had a business case and we've done, and the project charter and all that's done, so we're moving through that. As far as sustainability, we hired a COPD coordinator, so to do this work, it's focused attention, timely manner. And one of the roles of that coordinator is to ensure that we have a sustainability plan in place once her temporary term position is over. So we are doing a central intake to her rate at the moment, so that we would have to then identify somebody to take on, that responsibility and other pieces that she may be doing right now. She's doing a lot of mentoring. Her background is a respiratory therapist, and she also has, comes from New Brunswick, their extramural home care program. So she's very comfortable with doing the home visits. So she's mentoring the nurses in those home visits. So the sustainability plan would be, how we're going to do that long term. So we need to come up with a plan on that.
Just to add what Carolyn said, I would say the feedback so far most compelling is that it's more integrated, the transition from hospital to home for these patients than we have had previously. So the patients, that 48-hour call and the timely home visit from primary care makes the system more integrated, more streamlined, the care, and that's noticed by patients and patients' family and staff. On the communication part, as a acute care RT, where is that linkage with the palliative home care program, that is vastly improved over what we previously had before we started the INSPIRED program. So those would be 2 takeaways, I think, is the compelling is better integrated care, and communication is more formalized, especially with palliative home care.
And the last thing I'll just add in is that, we developed like the flow diagram tools, one page of describing, we have a working group that will continue to monitor and oversee. We have a communications plan. So all those things are good, and we have lots of support from senior management. Our CEO is very supportive, so I believe we can sustain this and keep it going.
Fantastic. That's really helpful. Thank you so much. So what we'll do is we'll keep moving through. I'm going to go to Ottawa Hospitals, Wendy and Sherry next, and then what I'll do is I'll open it up to everybody. Feel free, so teams on the line, weigh into this in terms of what your thinking is on these questions as well. And then I'll also come to our faculty just if they have any further questions or thinking on this area as well. So first to Ottawa Hospital, Wendy and Sherry. We'd love to hear your insights on this.
I think similar to the last callers, having a collaborative model that facilitates the communication coordination across the care continuum has been key. We are the only facility in the entire Champlain-Lynn region that offers such a service from the largest teaching hospital. And the ability to guide patients in navigating the healthcare system, more of a patient-driven model, has been kind of one of our key lessons learned. The availability of follow-up care, we've potentially averted close to 10 ED visits just by calling the patients, listening to how they sound. They didn't sound well, so encouraging them to follow up with the primary care provider. And then we follow up after, and these patients have all received medications accordingly. And just, I think, engaging and empowering the patient. All of our patients, of course, receive action plans and have brought them to their primary care provider and or pharmacist. So empowering the patients on how to use their action plans, the proper terminology, and early recognition of symptoms, I think has been our key. Communication, we're fortunate at the Ottawa Hospital to have an electronic medical record. So all of our documentation, or all our interactions are documented online and then faxed to the appropriate care provider for follow-up care. I think those would probably be our most compelling lessons or impacts.
Wendy and Sherry, anything in terms of that you want to share in terms of patients enrolled at this point, or just some of the preliminary lessons learned from having the INSPIRED program in the field?
So currently we have about 70 patients enrolled in the program. 4 patients have passed away. 3 patients have withdrawn before the 30-day mark. 1 patient withdrew between 30 and 90 days. 250 patients did not meet the criteria, but we are tracking all of those. The majority of those patients are coming from nursing homes, retirement homes, out of town. 30 patients we didn't have the capacity to see, unfortunately. And then we've had about 5 patients who have been refused to enroll into the program. I think and then we've had actually 75% reduction in 30-day readmission rate in the patients that have met the 30-day threshold to date. I think for the patients, sorry, what was I going to say? Refusing to be enrolled, again, it's patient engagement. Patients really need to understand what the program is. A lot of these patients, unfortunately, have a lot of mental health issues, substance abuse issues, the patients that are refusing to be enrolled. I think does that answer your question?
And if I could just add to that.
Yeah, go for it.
I'm Sherry Daigle, I'm the clinical manager. Obviously, I'm not one doing the patient visits, but I do have a lesson learned and an impact from INSPIRED. My lesson learned would be that you can't wait for your program to be noticed by someone else. You have to make it noticed, and you have to bring it to the people who make the decisions on budget planning. You can't just wait around for things to happen. You really have to be out there.
It's a really good point, proactive, and it's partly why we framed this question the way we did, because it's one thing for you to see lessons and impacts, but I think it's really important, you know, on the one hand you want to be cautious because of course this is a pilot initiative and you know, you need to let this play out and see where the results land, but so long as you're communicating in that way, I mean, if you don't communicate it at all, then it will be a best kept secret. So we wanted to think about both, you know, the reasons that you think that this has legs in your organizational context, but then also the ways in which you're sharing that information with people on the team from a motivational standpoint, but also with others who stand to learn and help its sustainability in the long haul.
Yes.
So thanks so much. We'll go to Winnipeg Regional Health Authority. We've got Carol and Craig online there to share some of their thoughts on this. Carol.
Hi. Well, I think one of the big things that stands out for us as you know, being an impact or compelling is just how quickly everything has worked. So, for example, we implemented standardized physician order sets in emergency as patients are being admitted, and almost immediately people on the ward were giving us feedback about how the patients are settling earlier instead of having to chase physicians to get best practice meds on board, you know, 2, 3, 4 days into the admission. Patients are already settling first, second day of admission. We did a talk with our family physicians around the use of opioids in managing dyspnea because we have the family physicians who have admitting privileges. And again, within the week of the talk, we had people using the opioids, increasing the dosage to something that was more effective for the patient and so on. We've had, because of all these things, already, even though we've had a small number of people coming through the program, we're already seeing our lengths of stay down to about 6 days. We've implemented the action plans and followed up on those out into the community, and our community partners are indicating that people are already have used their action plans and averted hospital admissions. So, we just started all of this in the end of February, so it's just been incredible how quickly the interventions actually do work with the population. So I think that's one of our most compelling cases. I think, all of this data that we're getting around lengths of stay and so on, as well as patient stories, we're getting some incredible patient stories about how this has impacted their lives, is really important for us to feed back up through our teams and individuals who are working with these people, but also to our senior leaders and broader communities. So we do that with communiques, where we let them know where we're at in the project, what the results to date are, and include a patient story, so it really drives it home to a person-centered point of view. So that, I think, has been very important for us. And the other thing I think that has been a compelling lesson is that we've tried to build in our processes into our current processes as much as possible, so that the change has been as minimal as possible. So we've really tried to integrate the work that we're doing from the beginning, and I think that has allowed us to have some of these big impacts as quickly as we did.
Yeah, and I guess in terms of communication, so Carol and I have done a bit of a dog and pony show, if you will, around the health region, because we do have a lot of facilities and a lot of programs that interact with these patients, and we've already seen and sort of collaborated with some of the other facilities who are interested in implementing a lot of the tools that have already been developed through this project and other ones that we've been involved with that we're linking together. So we have other facilities in the health region, acute care facilities, for example, that are looking at the inpatient physician orders and different parts of the work that we've done. So we're already starting to see some spread across the health region, which has been fantastic.
All right, thank you so much. And I can already start to see how some of this, I think some of your response here is going to dovetail when we get to the portion on sort of facilitators and what's been assisting so far in ramping up your efforts. So we'll move now, and actually I'm going to move ahead to the next slide. Rick Steeney is with us from Saskatoon Health Region. So Rick, this is your slide. I'll just reiterate the questions there, but the compelling lessons and impacts from your INSPIRED work so far, and the ways in which you're communicating that to your team and senior management and a broader community.
Well, thank you very much. I guess we're sort of looking at this in a slightly different perspective. Our program has operated for a few years now, and we were able to demonstrate to senior leadership and the health region the effectiveness of the COPD program and pulmonary rehab at preventing hospital utilization, improving the patient's quality of life, improving their care. So we do have buy-in, and we are currently sustained in our program and service. But as we started to reflect back on where we're at, we began to wonder about the people that, for whatever reasons, have chosen not to engage in our program and service. It seems baffling that if we are able to do good work with people and they benefit and health improve, why people would choose not to join us. So with that in mind, we entered into this project looking at what the barriers to participation were, why people were coming to emergency, what their profile was, what was their background, what were their needs, what were their challenges. And so with this, we're beginning to see a pattern that there are people that are very eager to participate. When we meet with them, they buy in very quickly, and they join our standard program, and they do very well. But then there's people that are less ready to participate. And we're starting to see patterns into why that is the case. And social determinants of health play a large role in that. And as we all know, that mental health and addictions create quite a barrier to any successful participation in programs. And when we looked at the COPD data from emergency departments, we found that unfortunately a large percentage of people using emergency are there because they're probably approaching end of life. And unlike some of the other regions, I think across the country, we do not have a chronic disease palliative service in our region, which we can certainly see is definitely needed. We've been collecting stories from our experiences to outline the challenges that people face, and we've been presenting those and passing them on to our staff and our senior leadership, which has been very supportive. So we're still very much at a learning stage. How do we address some of these services? How do we measure it and then present it on to leadership for sustainability?
Fantastic, Rick. Thanks so much. And what a great example of putting forward that question of, is what you're doing delivering what you thought it would? And if not, why not? So, why would people decline? And taking that as an area to look at and improve makes a lot of great sense. So thanks for sharing that perspective. So for folks who want to weigh in on this and provide some of what you're learning, I'm just going to recount there's 2 phone lines, an English line and a French line. If you're not already signed into the phone, we're going to put this in the chat box as well. But if you wish to share your thoughts verbally and you're on the phone, you can simply press *1. If you're not yet on the phone but you want to join that way, then the English line, if you've got your pens ready, it's 1-855-856-8710. That's the English line. The French line, 1-866-271-3684. And then you once again press *1. We've got the detail up there in the chat. If you do dial in by phone, then you need to turn off your computer speakers. I will go to our faculty just in case faculty, Kathy, Sean, Graham, that you guys have questions or reflections for the teams who've presented or other thoughts on this. So I'll go to, can I open the lines for all the speakers at once? Okay, producers are telling me one at a time. So Kathy, I'm going to start with you, but I'll start with Graham or Sean the next time around. So Kathy and Jillian.
Can you hear me, Jen?
I sure can.
Jillian and I actually were just sitting here commenting on the fact that it's amazing and wonderful and absolutely terrific to hear how well things are working for the teams that are reporting. It's really amazing for us because we clearly, it worked well here in Halifax, and I think being able to see how it's been able to be adapted in other areas and still be a very positive experience and taking people where they needed to go has been great feedback for us as well. So other than that, I don't think we had anything more particularly to add for each team. I did have one comment. The team that was talking about, I think it was Winnipeg, that had done the dog and pony show to the region. So just the idea that other areas in the region were thinking about or showing an interest in implementing the program, but I was a little concerned about the bits of the program because I think we're pretty wedded to the fact that there are certain elements that need to be there for the program to perhaps have the biggest bang for its buck. However, yeah, you do have to start somewhere, so it's great to know that there's an interest out there.
Yeah, it's a really good point. And Winnipeg team, if you want to chime in on this, I'll come back to you. I'm going to go to Sean here now.
Echo those thoughts. And I think one of the things that struck me, and I think it's probably worth thinking about moving forward, is certainly there is a large population that INSPIRE can address, but there is also this large population, as you said, that the social determinants of health and serious mental illness drive utilization much more, and whether that population should be targeted very differently. because I don't think it's the right population for this intervention. And then the second piece that I sort of tweaked my ears is there something that we can put into place or think about for those teams that are operating where there is not specialist palliative care to avoid these patients coming into the emergency department for their last breaths, particularly given that dying from COPD really requires sort of very aggressive active medical management right at the hours of life. And is there a way that that we could facilitate home deaths in the absence of specialist palliative care teams, or B, if that's not the case, can we have a plan for a direct admission so these folks avoid spending time in the emergency department in their last hours? And just something to ponder and think about.
That's really really helpful, and actually Kelly is very happy here because you said a boot, and she's never heard anyone say that before, Sean. We're going to go to Graham. Graham, anything you want to weigh in on this?
Well, nobody says a boot quite like Sean Morrison, that's for sure. So this is all good and great to hear. I mean, I particularly like hearing about the positive stories. And I think one of the things that we should make sure we do at the end of the collaborative is pull these stories together from across the country, because I think it will make it an incredibly compelling case. And while we can't hit all people with COPD, as long as we're hitting as many as we reasonably can and being fairly successful about it, then I think the impact could be huge.
Totally agree. So what I'll do is I'll introduce the next set of questions, and then teams who just presented, if there was anything you wanted to say sort of in response, as I come to you, you can start with that before you go to these questions. So Carol and Craig, I'd mentioned I'd come back to you, and I will do that in this portion. So we want to move to the next section on facilitators and mitigating strategies, and we tried at all possible to avoid that word barriers, because we want to be thinking about workarounds and ways of moving forward. So, in this question, we're thinking about what are the central facilitators that have really helped you so far. If you feel you've addressed that, that's okay. You can skip ahead or reiterate. What are the barriers that you're facing, and importantly, what mitigating strategies are you using or plan to use to address it? And then finally, where do you still need help where this community practice could potentially help provide some insights as to what to do next? So I'm going to start with Ottawa Hospital, and then I'll go to Health PEI, Saskatoon, and I'll finish off with Winnipeg in this round. So first to Wendy and Sherry at Ottawa Hospital.
I think during our proposal stage, we engage the community partners, identifying that it's truly a community need, and how can we work together to make this work in the Champlain region. I think that was one of our kind of central facilitators that really got a buy-in from the entire community. Presenting to the program to the physicians, managers, and clinicians as this is how we are prepared to help you, help your patients. And this generated buy-in from the hospital staff and physicians. There's multiple programs going on throughout the hospital. They didn't want to have to have any other workload added to their daily workload, so initially we went in self-referring, and this was completely, our program didn't kind of compromise their day in whatsoever. Seeking permission from physicians, directors, and managers to see patients on their respective units. Again, that we weren't barreling through the hospital implementing this program, but actually seeking permission from the individuals involved. And then presenting ourselves to patients as being part of the healthcare team. Initially, we went in saying we're a CVD Outreach program, and as soon as a lot of these patients heard the word program, the walls went up. So now we present it as we're part of their healthcare team, helping them to learn more about their COPD. Some of the barriers, mitigating strategies, initial recruitment, again, I had alluded to that we self-referred initially. Now with positive results, we've developed a standardized referral form, so we are getting referrals from physicians. There's some diagnostic barriers that continue. A lot of patients come in, I know this is not Ottawa Hospital alone, come in with a diagnosis of COPD because they smoke, but they've had no formal PFTs. So what we do is we request PFTs to be ordered when the patient is stable. There's ongoing medication challenges in both hospital and community. So in hospital, we're making recommendations to the appropriate medication regime. We've also met with pharmacy to identify the gaps. They're in the perfect position in the hospital. They attend rounds, and they are experts in the field. So we've identified gaps to them, and they are going to look towards one another. Potentially they can kind of fill those gaps. I'm not sure if most people are aware of the financial climate at the Ottawa Hospital. There was a $26 million budget cut this year and $12 million cuts last Thursday. So it's difficult to implement and monitor a new program in the context of a program downsizing. So I think we're going at it from a quality perspective. So we've presented to the Chief Quality Performance Officer, as well as the Champlain Lung Health Network, which included a senior integration specialist from the LIN. So we're presenting it like a quality program. We've obviously made some, with 75% decrease in readmission rate, we've reduced numbers significantly, but it's more the, I guess, the quality-based procedures that we're addressing, empowering and engaging patients that our quality performance officer is most, I think, impressed with. Sherry, I don't think there's anything else. I think that's it.
All right, thank you guys so much. Really appreciate it. We're going to move to Health PEI. So back to Carolyn and Kenny.
So just to reiterate what others have said, certainly our facilitators have been that we've had senior management support, and for those that aren't aware, it is actually even in our business plan for Health PEI. So being a strategic priority, we're getting support. We used the funding that we received to hire a dedicated coordinator, which I really think was essential in moving things forward in a timely manner, because it's really hard to do off the side of your desk, and she's actually doing most of the leg work. And that, again, is really important because our project's provincial in nature, and it's crossing quite a few departments. So at the beginning, we thought, it was very important to get the buy-in, like others. So we actually held an initial planning session, bringing in stakeholders from across the island and from various departments just to explain what the INSPIRED program was. We talked about the Halifax model. We talked about the different components, such as, the 48-hour phone call, the home visits, the spiritual care, advanced care planning, the different pieces, and asked for input from the stakeholders to make it their idea. And then we actually had some working groups, and we got approval from this stakeholder group then to put together a working group to start working out the logistics and operationalize the agreement on the components, the what, and how we were actually going to implement that. Now, I'll give you share a little story with you. So, of course, initially the home visit, 48-hour phone call was not an issue at one site. It was an issue at another site. However, we did, ask them to try it. We started at the first site and demonstrated that, hey, this is working, and positive feedback. And then for the home visits, we were challenged on who was going to do the home visits, because like everybody else, we had, we're working within resources from within. And, initially everybody said, oh, that's home care's role, that's home care's job. But when we started looking at the patients, that doesn't necessarily mean they were on home care, because they may only be they may not be on home care, or they don't qualify for the nursing component of home care because they they can leave their house and go to church, and they can access services through primary care. So to make a long story short, initially the primary care network managers were saying, well, that's home care's role, but as we more talked the way through it, and had support from the director, all of a sudden one day, one of the primary care network managers says, well, that's the primary care nurses. They're the COPD educated nurses. They're the ones that should be doing it. And I'm like, yay, yay, their idea. And I said, that's change management at its best. So then what we did, once we got buy-in all the components and worked out the logistics, we actually had a training day. We pulled all the primary care nurses together for a one-day training. Part of that was, again, we don't have a spiritual care worker that can actually go and do the advanced care planning, but what we did have was the support from the spiritual care worker in helping to train our nurses in advanced care planning. So spreading our reach so that we can actually do that part. And again, there was some initial, how long is it going to take in the, for the home visits? And again, in the long term, it's turned out they're shocked and pleased that it's quite manageable and not without, too much demand on their workload. The other big thing we did was a phased approach. As I mentioned, it was provincial in nature. So we started at our largest hospital, the Queen Elizabeth Hospital here in Charlottetown. That was rolled out on March 31st. And then we turned our attention to our next largest hospital, Prince County Hospital, which was rolled out on May 19th. And so once the dust settled here a little bit, we're very soon going to be turning our attention to, we have 4 community hospitals. And the other thing is our initial scope was just including inpatients, but we want to expand that scope to then look at including patients that are arriving at the emergency department for 3 or more visits as per, again, what we use the same eligibility criteria as the Halifax. So some of the central facilities has been the opportunity for input, sharing their ideas, helping to work out the kinks. As far as barriers that we're facing and some mitigating strategies, one network that we have 5 networks, and one of them has had a higher number of referrals than the other one, so there's been a little bit of imbalance in workload. So it's been challenging to schedule those home visits within 1 to 2 weeks. So what we had to do was we pulled in a nurse from another network or area, site, because there's 5 networks, but there's 10 sites, to help out and take some of give some relief to that other nurse. And so we're monitoring the work demands and sharing that with the director to show the imbalance in workload and hopefully get some resolution to that without having to continually pull from another site. Another big challenge that we've had is we've been using the COPD action plans from the Canadian Thoracic Society, and all of a sudden we can't get them, and they're currently not printing anymore for another 3 to 4 months. And so we've actually been having some challenges for the past year. So we're really at this point looking at some other opportunities on what we could do with that, because I know the simple solution is, they say, what we've been told is use the online version, the PDF, it populates, but that's not as easy as it sounds when you've got, in health centers, physicians and nurses that don't have, easy access to the computer and the printer, or they have to stop and photocopy 3 copies. It makes it a little bit more challenging. So we need to figure out how we make it as easy as possible for them to do the right thing in a timely manner. Because otherwise, if it's not easy, it doesn't necessarily happen as consistency as we would like. We have encountered some providers that have not been completely sold on the model. For example, the respiratory therapist making the phone calls. And again, primary care nurses providing home visits. But as we're showing the benefits and spreading the news, we're starting to get more and more buy-in. And what we really did to mitigate that was just as we recognize your concerns, and what we're asking you to do is just, give us a few months, and then we'll reevaluate and we'll regroup and see how things are going. And like I said, things are, our buy-in's getting bigger and bigger and bigger. Another challenge is, again, data collection being provincial in nature. We do have an Excel spreadsheet that with a shared drive with all the primary care nurses. So we're doing that. Hopefully someday we'll get an EMR to make sharing of information and easy reporting a little bit easier. Anything to add?
Just to add to what Carolyn said is the importance of physician engagement. I don't think we're quite there with all physicians totally engaged in the program, so hopefully with Dr. Rocker's visit here in late June, we'll have more participation amongst the physicians, and that ongoing struggles trying to get the action plan to triplicate, because the first one goes to the pharmacy, and the College of Pharmacists here doesn't want a photocopy action plan, so it's just a workflow issue.
All right, thanks, guys. So just a small list of challenges, right? No, I mean, it's really helpful, and I bet others on the line are experiencing many of the same things. And I think it's interesting what you say around, identifying even what might be perceived as the smallest barrier, like a printing issue, because you do want to make it easy for people to do the right thing. And if all that's stopping them from doing it is having a printed copy in hand, well, okay, let's figure out what we can do about that.
Right.
Appreciate that. So we're going to go back to Rick at Saskatoon. So Rick, over to you.
Oh, thank you. We engaged in, the Saskatoon Health Region has been focused on ER utilizations this past while, and we have a group called the Respiratory Operations Group that meets regularly to discuss issues around respiratory care, and an arm of that sprung out, I guess, to allow us to be able to do our project. So we engaged the ER team, the manager, etc., is on the operations group. The respirologists are on the group, and other health departments or departments within our health region also sit on the operations group. So this is a venue for us to be able to discuss the challenges and what's working and what isn't working within our own system. We hired a nurse navigator in one of the 3 hospitals to see if we were able to identify the challenges patients were having when they hit the ER with their COPD and how they were being managed, triaged, and discharged, and then what services were available when they went home from that discharge, and then why did they come back to emergency within a short period of time, perhaps. From that, we then went into this project that we're now talking about. We hired a social worker who would then be linked up with patients to see if they could influence some of the challenges the patients faced when they were discharged into the community and what prevented them from being successful at staying in the community and not coming back to ER. So I think our strategy has mostly been structurally to work through the respiratory operations group and keeping the members of the healthcare team informed and having buy-in to the project and seeing how it's working. That's about it, I think.
All right, thanks, Rick. Really helpful. And then last but never least, Winnipeg. We're going to hear from you again. So Carol and Craig, your insights on this.
So I will maybe just address the comments around the the bits and pieces of the project with the dog and pony show. I guess what we've done in Winnipeg is that we've looked at the transition of care from hospital to home, but we also had a previous project in the region that looked at inpatient care. And so for that project, we've added on the learnings from that project into this project. So things like the order set for physicians in emergencies, predetermined admission orders so that you get the right referrals happening earlier on and so on, an inpatient protocol for the interprofessional team. So those are the pieces that we've added up front to then the whole INSPIRED piece that reaches out into the community. And so when Craig was talking about the bits and pieces, the hospitals are all interested in the full piece, but they can start with improving their physician order sets, improving how their interprofessional team works in the hospital. Those kinds of things are the pieces that they're talking about adapting early. As we continue to work through some of the challenges of how we will make this work within the transition to the community within our existing resources. So that's just to clarify that piece of it. But some of the central facilitators that we have found is that I guess we started with a very common goal, so we're all aligned in the goal that we have, and that goal is completely aligned with our regional strategic plan or strategies and our regional priorities. And so because of that, we have very strong leadership support. And so even though we're starting with, like in the Winnipeg region includes all of the hospitals within the region. They include all of the community programs, some long-term care, palliative care, home care, all of those kinds of things. So our project is actually sponsored by the CEO of the entire region. So even though we're starting with one hospital and a number of the community players, the idea is to extend it into the rest of the region. So we do have very strong leadership support, and it's all very aligned with where the region wants to go, and we have the common goal. I think also some of our success factors are that we've started pretty small, and we realize that we're starting small, but in starting small, we've allowed to test things and to try things and to get people's buy-in. And the idea is that we'll start with a small test and sort of grow it in sort of increasing circles around it. So that's, I think, been one of our pieces. Certainly, a success factor or facilitator is that we've been very inclusive of our partnerships. We are completely interprofessional, and we collaborate interprofessionally. So within the hospital, all professions are represented at the table. And then we have our 4 strong community partners, our palliative care program, our home care program, community therapy services, and our regional pulmonary rehab program. So we're very inclusive. We have huge tables that we sit around, which sometimes present their own challenges, but I think it's very important to have all the voices represented and equal. We've done some big, so that there's an opportunity to learn from each other. We've had a big lean event where we mapped out the processes from start to finish, and everybody was in the room. I don't know, there was 40 or 50 of us from community to hospital, and I think that was really important in helping us to learn from with and about each other, but also to really understand our roles and to build some relationships and trust across our sectors. And so I think that's been really important. We've always kept it person-centered. Whenever we run into difficulty, we focus back on the patient, and everyone is just really very passionate about improving things for the patient or the person with COPD and their families. So that has always been something that has facilitated us through rougher waters. One of the pieces that really helped, because we have a lot of moving parts to our initiative. There's a lot going on. And so when we initiated it, we started to have weekly process meetings. And so just the key players who were involved came to this meeting, and it was basically, so how did we do today? Do we have a patient enrolled? How do we know we haven't missed someone on admission? Are we checking the things? What issues have come up? So it's all those little bits and pieces that some of the other teams have talked about. There's always little tiny barriers. How do you print something, or how does something get to there? So we would meet weekly, and we worked our way through those things and then extended it into bi-weekly meetings. And I think that really helped us work our way through some of those process bits. Some of the challenges, I guess, is change management is always a challenge. So we're asking people to change some of the things that they've been doing in different ways, and that is not always easy to do, and so we're always trying to find ways to help with that. So it's hard sometimes to change processes, and even when we have had processes in place, staying the course on those processes has been challenging as well. We start to veer off to the left or veer off to the right, and things start to fall a little apart at that point. So we've had to be really on top of those meetings. I think another sort of challenge for us is just the whole sustaining. Although we've tried to build everything into processes that are already in place, make it as simple and as easy as possible for people, we still do have spread that needs to occur, and there is a bit of a mindset. You hear people saying, well, this is done in September, right? Or when are we finished with this? And so, even though we're trying throughout to build this concept of this is here, this is going to expand and improve, we're still fighting that, the end of the CFHI involvement is kind of the end. So we still have work to do on that piece of it. And then another challenge, which is sometimes a positive too, is that we are tasked to do this within existing resources. So I say it's a positive in that sometimes our experience has been is when you do an initiative that has external money for a period of time, that's great until that period of time is up. And then what happens if you don't get sustained funding is things fall off. So by challenging us to work within our existing funding, we're really asking us to really take a long, hard look at how we're doing business currently and trying to find ways of improving the way we're doing to make this happen within the resources we have. And so I think for us, some of our biggest challenges is figuring out how to do this within our community piece. We're lucky in that we have a very strong and good home care respiratory program, and we've been surprised to find that all of our patients so far actually have been attached to home care, and most of them attached to the home care respiratory services program. So the challenge for us is to just figure out how can we do this in a sustainable way for the program and allow that to happen. Where we still need help, I think we're still not doing as good a job as we can in engaging the patients and families in the work that we're doing and in helping us determine the work that we should do. So we're still not quite there yet, I think, in feeling that we're strong in that area. We're working on engaging our fee-for-service physician partners, as we heard another participants talking about trying to get them engaged to be more upstream, I guess, with some of the self-management and education and action plans and so on. And another group that we actually started with as an intentional exclusion, as in we talked about keeping our PDSA cycles small or our group small at the beginning. We're concomitant diagnosis of congestive heart failure. So we feel that we need to, the next phase around, we need to pull that group in, and we could need some support, I guess, in understanding just how best to add that, element of management in.
Yeah, I mean, just to add to the CHF piece, when in a previous project, we really did find that significant CHF particularly really complicated the picture, and while from a COPD point of view, we could manage the patients very well and get their COPD handled, and they were, from that point of view, doing very well. The CHF really did complicate, the overall lengths of stay and the comorbidities and the other issues that came up. So trying to figure out a way to handle that group similarly, but with some different tweaks around their CHF has presented some challenges, I guess, in a lot of ways in the past few years here. Just to also reiterate what Carol has been saying, it's been really, really great to have such a big team, even though, again, large tables, lots of voices does present some challenges in getting through everything in a timely fashion. It's been really, really great to be able to learn from each other and have a good understanding of what actually happens in the community compared to what actually happens in an acute care, so we sort of can see where the other players that are involved have come from. It's good that we have a really fairly robust kind of community programming that, we've been able to link a lot of those pieces together, and just a little further to go, and I think we'll have a really good system in place.
All right, thanks, Craig, and thanks, Carol. I'm going to come back to our faculty, and I've got a couple things to weigh in there as well. I'll go to Sean first to see what he thinks about this. Ha-ha.
Oh, give me a break. No, I really actually nothing to add, and don't waste the time on my thoughts. It's really exciting to hear what people are doing and the success, and let me just leave it at that.
Yeah, and I think it's a time right now where everybody's going through these types of barriers, and so being able to hear them and name them so that we can work through them together is really helpful. Graham, anything you want to weigh in on that?
Well, only from the point of view that it just sees that nothing's impossible, really. And I think that's the sort of mindset that all the teams most of the teams have adopted. And for those who are a little slower out of the starting blocks, I mean, to hear how other teams have overcome barriers and got around them, I think will be incredibly helpful. And if there are teams that are not on the call that would benefit, we should make sure that they hear the recording at some point.
Yeah, it's a really good point. I think Meg, who's on the line in New Brunswick, but will be making her way to the Halifax Roundtable tomorrow, a good message to reinforce at our remaining roundtables that, these are archived and they're a great resource. If you can't be here live, we get it. There's obviously clinical responsibilities and managerial responsibilities, but these are great resources to hear about some of the same issues that you're probably encountering and some of the ways in which teams are addressing them. Kathy, Gillian.
Just a quick thought. So we actually got an email just today from CTS saying that the action plans aren't available. So same issue there as Carolyn. But in the past, we've actually brought one to the print shop, to any print shop, and gotten them printed ourselves. So that's what we're going to have to do again as well.
Yeah, and that's I think a quick fix one. Graham signed us up, I think, to help with some of that printing, and I don't think that would be a tremendous cost on our part to help facilitate that. So we'll certainly touch base with the teams and see if that's an issue across the board, and if there's a way that we, and possibly in partnership with BI, can help alleviate that issue. It's one less barrier to encounter in the day-to-day.
Yeah. So any of the simple fixes are great.
Yeah. The other thing I'd say is on that, we've talked a little bit about, and I really like, Carol, how you raised sort of this need to work more in partnership with patients, and I think that INSPIRED in Halifax and the INSPIRED Collaborative, we've done a lot of needs finding with patients and families and developed, it's an initiative that addresses needs, but it's not necessarily a co-designed intervention. And we actually have a webinar. It's available to everybody. It's 2 parts. So the first part actually happened a couple of weeks ago, or about a month ago now, actually. That was on in-sourcing innovation, truly about co-design, and it featured Kaiser Permanente, who's doing some tremendously interesting work on co-design and using video ethnography and other types of tools and approaches to true co-design. We heard from the South Central Foundation in Alaska, which has developed the NUCA model of care. They had some great insights, and then also Children's Hospital of Eastern Ontario shared some of the work that they're doing on experience-based co-design. So we're going to actually have a subsequent Part 2 webinar with both Kaiser and CHIO next week that I'd encourage you to participate in, because it will focus on not just co-design, but also what you've been talking about around combining the data that you're capturing from this work with the patient narrative and story. And so they're going to be sharing some of the ways in which they triangulate and use that information in a complementary fashion. Again, you don't need to listen to it live. You can have access to that archive. And then the other thing I would just say is that I think a lot, keep in mind that a lot can be mitigated at the provider-patient level. Yes, in matters of resourcing and resource allocation and reallocation, you need that shared buy-in. But it is helpful. One of the reasons we frame this around mitigating strategies is to say, what can you do? What's going to be the small step that you take? Recognizing that there's going to be some things that are your control, but that will help put the favor on your side. So keep operating on those things that you can have leverage around. Don't lose sight of the broader picture, but don't also get caught up or stop because you encounter a barrier. You need to think about other ways of making those small steps toward a bigger change. So we're going to go to our last set of questions. Teams on the line, you of course got an opportunity to weigh in here. I'll come to you if I see a *1 dial in, and you can also certainly weigh in on the chat. But I know we're typically a quiet crowd, so it's okay. I won't hold it against anyone. So our last set of questions, we're looking at this conversation on scale, and for the roundtable teams, when we come to your sites, Halifax tomorrow, Edmonton Monday, and we're going to be in Quebec City end of next week, we're going to talk more about what scale means as part of our conversations at those roundtables. But for the purposes of today, we wanted to hear from a few teams who've thought about this. So when it comes to scale, or reaching all of those who stand to benefit from an INSPIRED-like approach, or all the providers who could stand to be involved, what do you think scale means to you, and where are you relative to that target? So just your initial thinking on that, and I think in this case, we will start with, Rick, I'm going to start with you, and then we'll go Winnipeg, Health PEI, and we'll finish with Ottawa Hospital for this one. So first, Saskatoon.
Well, thanks very much. I get to start off with the question I had the most trouble looking at and trying to come up with an answer.
Exactly. And you know what? If people don't still struggle with this, that's a problem. This is one where we should struggle with a lot. Yeah.
So what I think of when I think of full scale is that we look at the trajectory of the disease itself, and this full scale of COPD should embrace the public documents around smoking, access to tobacco. So preventing a disease is by far the best way of managing it. So part of the full scale would be to look upstream. Looking upstream a little bit closer to us would also then include more early diagnosis, the identification of disease, making sure that family physicians are looking at proper pulmonary function testing in patients that are at risk of perhaps developing COPD. So do they have that capacity in their clinics? Do they have people that can interpret? So building capacity and the realization that we need to be diagnosing this disease earlier to try and initiate some interventions further upstream. Historically, we've been sort of focusing our approach anyways here on patients that go to a hospital. So once they've been admitted a time or two, we are connecting with them. And with that, we were finding that some people are quite anxious to join, and those people who do very well. The program definitely works and has been demonstrated to do that. But unfortunately, there again, we found that many people would also say they weren't interested in joining a program. So we need to think about how do we engage those folks to some type of service. And I suspect that what we're going to be offering to them is something different than the standard program that we currently offer. And the other extension to this, I guess, when I think of full scale, is something that other regions already have, but unfortunately we don't. And that is once people reach a point where they're approaching end of life, that we need to be able to transition their connection to the health region towards end-of-life issues in palliative care. So when I think of full scale, it's a broad spectrum, and I think when we look at how we intervene with it, it's going to be at multiple layers. But one of the learnings that we have right now, I think, in terms of this is that it appears that we know that we're in a people's business, that much of what we do is connecting with people, and when we make a personal connection with people, they're more willing to engage with us. Healthcare is still about relationships. And are we preparing staff with the skills, knowledge, and ability to be better at creating these relationships? Are they able to create them in a more timely fashion? So how do we address that? Do we provide some services for staff to become better at skills along this line so that patients might be more ready to join into their care and engage with our system? So I guess full scale, that's one that troubles me the most and is probably the most complicated piece of the questions. Thank you.
Thanks, Rick. And I think that's a really helpful perspective because, you said a few things in there that are about scale. So that pop health, focus on disease prevention and looking upstream and thinking about the whole population that would stand to benefit. I think it's a really practical way of thinking about it. In conjunction with what you're saying on sort of this continuum of service offerings, because a program, a full suite of program, might not be what works for everyone. So how do you still meet people where they are? And the preparedness of providers makes a lot of sense. So those are definitely scale-type questions to be asking. And like I said, I think this is a question we should struggle with because for all of us, it will be the target that we set for which we say, where are we relative to what we see as scale? And I would say, I put that same challenge to the team in Halifax in terms of, are you reaching all the patients and families who stand to benefit? Where are you relative to that target? And it really forces you to think about benefit, to whom, in what terms, in what ways. So I'll move to Winnipeg. So back to Carol and Craig, your thoughts on this?
Yes, well, certainly I come from the Chronic Disease Collaborative, so from my perspective, I take a fairly big and wide view of the scale, just like Rick was talking about, and for me, it goes even beyond COPD. Is what are the learnings here that translate to other chronic diseases? Because there's lots of crossover learning here that you know you can get into a system around chronic diseases, but we've tried, so you have this big picture view, and then you have to go to on the ground and where you're at. So I'll give you some examples of some scale we've achieved and or are actively pursuing, and sort of future plans. So, for example, with the physician order set when people first come into the hospital, standardizing best practice in our hospitals, we started off with that just for the patients that were coming on to INSPIRED. But as soon as the physicians started to use it, they loved it, and so now for that hospital, they're using it for all COPD patients who come in the door. So we've already achieved some scale on that. One of the other pieces that we introduced as part of the order set and admission orders is that we really challenged them to start thinking about nicotine replacement as part of those standing orders, which we put in there. And I think the penny dropped for them when we got into discussions around that. Everyone went to smoking cessation, and you know the argument started, well, they're not ready for smoking cessation and this and that. And then we had a great dialogue around, but wait a minute, we're talking about nicotine replacement to make the patient more comfortable while they're in the hospital here. It's an addiction. And that may open the door for smoking cessation down the road, but you know, we can start with nicotine replacement, and the penny dropped for them right then and there. It's like, oh, yes, we can do this. And so now they've started to do that, and the hospital now is talking about how can they do that for all patients coming in the door who are smoking. So that's a place of spread there as well. The other thing, the other interesting thing is we tied this in. We have just a newly minted new regional evidence-informed practice guideline around smoking and nicotine and all of that. That is just hot off the press and being rolled out, and so we've really integrated that into our work. And in fact, upstream, when this was being built and we knew we had issues with COPD, we made sure that the screening for COPD was built into the smoking evidence guidelines. So that's all kind of built in and streamlined now. As far as the hospital goes, we started very small. We started on one ward. There's 3 different medicine wards, but we started on one ward. So now the spread for us would be going to building in the other wards, and so we're going to have to start to actively integrating that over the next month or 2, so building it in the other wards. There were some exclusions that we talked about previously. We're going to have to start to think about what do we do with our CHF patients and how do we include them. We had excluded language barriers, but we do have language services within our region that can act as translators and so on, so we're going to have to start to think about how we bring that into the fold. And we had looked at sort of mental health cognitive impairment as an exclusion at this point, but again, we're going to have to start to look at how we address those within this. From there, we are looking at going to the other. We have 6 hospitals within the health region, so looking at going to the other hospitals, as we'd said, 3 of them, well, 4 of them actually are actively involved with understanding what we're doing with this initiative, being on board with what we're doing, and starting to dip the toe in the water with some of the pieces that they may begin to bring into their facilities. So they're already aware of and starting to move towards some of that. One of the pieces that we worked on is that we had all of our different community groups and the professionals in the hospital get together, and we standardized our self-management education tools. So they got together and chose a tool that they want to do. So now from hospital all the way back into the community, we're all singing from the same songbook, understanding you know what we're teaching and with what tool. We went to the respirologists, and they were very excited about that, and so they're going to take that back into their outpatient clinics where they're seeing patients and using the same type of tools. So we're standardized across that. We're starting to, on our list, and we've just, again, dipped our toe in the water, this is to start to bring together the role of the respirologists and the palliative care physicians, and we're fuzzy on the roles when it comes to end of life between these two groups. We are blessed to have a very strong palliative care program within Winnipeg, and so we've started some of that work, but more to come, and it was just great when we had our panel discussion around the use of opioids. We had a palliative care physician and a respirologist, and at the end of the after the end of the dialogue, which was great with the family physicians, the respirologist said to the palliative care physician, you know what, I think I need to be using opioids way more often in my practice and sooner. And so it was great to see that those dialogues starting to come together, and we need to further explore the roles of when do you involve which and so on. And then the last thing within our last but not least thing is the role of primary care, which is huge. And so we're just starting to tap into that. We had a project that looked at one of our primary care sites, and it's centered really around diagnosing COPD. As we all know, it's hugely underdiagnosed. So it's a project that's looking at how do we get people into spirometry and how do we do this and so on. And so because of that, we're now starting to develop a regional spirometry community primary care spirometry model to help bring that closer to the primary care homes within Winnipeg, and it will tie into to all of this other work we're doing. So we're trying to take a big picture view. We've got lots of irons in different fires, and we're just trying to keep it all connected and knitted together so we're not going off down different roads.
Yeah, so when I look at the slide that's on the screen right now, you know, how many patients do you intend to reach and how many providers and across what number of sites? I mean, it would sure be nice to just say the answer is all of them, you know, but I guess the scale of COPD in Canada is just huge, and it's really hard to wrap your head around exactly what that means, and it means something different in, you know, every context around the country. I mean, one of the things that we haven't sort of mentioned yet is, you know, the INSPIRED intervention really is geared towards the sickest of the COPD patients, the MRC4s and 5s, and the people that have difficulty, you know, getting out of their house and all of those sorts of things. But what about the 1s and 2s and the people who are in their 40s and have been smoking for 20 years and just have the mildest of symptoms that, man, if we could intervene now, we could really make a huge difference. So trying to think about, you know, how do we, you know, like Rick says, move some of these things upstream so that we can really prevent the bulk of the morbidity down the road would be fantastic. What the exact answer is to doing that, we don't know, but I think, you know, there's lots of things that we can try and sort of play with until we reach something that helps.
Thanks, Craig. That's really helpful. And I mean, I think it's, you know, this is a provocative question around how many patients do you intend to reach, but it's intended to help teams work through, you know, numbers of patient population that you'll reach so you can think about things like the capacity required to get there. It'll be interesting to hear what your guys' thoughts are on all this post-roundtable, because we're going to spend a significant part of our days, these upcoming roundtables, talking about this and floating some examples. Health PEI will come to next, and then we're going to wrap with Ottawa Hospital. And I got a few messages before we close today's webinar, because we are closing today's webinar at 1:30. But I'll ask that you stick around till that point, because I definitely want to share with you some key messages of a few upcoming things, and also give you a heads up that in this slide deck, there are some really useful information that we've pulled from that midpoint survey you all participated in. So it has details from 18 to almost all 19 teams that I think you'll find really beneficial, but we'll go over those details in full view at the next webinar. That's a measurement webinar. So first to Health PEI, and then we'll go to Ottawa Hospital.
Okay. So thanks again. So as I indicated before, we rolled out at our 2 largest hospitals, but we have 4 community hospitals. And so, and the other thing is we started with inpatients. So for our our full-scale reach, if you want to call it, is we need to expand the scope to include patients arriving at ED, and so how do we, it's more the issue around identification, and at the QEH, I think that's going to be easier than at the Prince County Hospital, but we need to look at that, though we already actually brought in a couple of ED patients that have been identified. And at the community hospital, it's going to be a little bit more challenging because there's no respiratory therapist at the community hospital, so we'll have to meet and look to see and identify a hospital staff that would take this on, 24/7 role. The other, and so if you look at our estimated patient volume, so right now we have about 400 patients, unique patients discharged from those 6 hospitals per year, the largest being at the QEH, as I indicated again before. But that's just inpatient, so that doesn't include people arriving at ED. The other thing that keeps coming up is like the hospital group recently at the QEH said, well, how come we're not looking at long-term care patients because, you know, they have flare-ups, et cetera. So, you know, we said, okay, we will look at that once we get through what we've already planned on and what would that look like. So again, it's just building on the model and how do we adapt it to different environments. If you want to look at how many providers, we have trained 17 primary care nurses across the province with 10 sites. And I thought it was very interesting what Rick in Saskatoon was looking at with full scale, because one of the interesting things is for our COPD coordinator hired for this project, that was 3 days a week, though we did get some funding from the Department of Health to also give a lift to our Ottawa Model Smoking Cessation program. So we've actually extended her to full-time, and she's 2 days a week with the Ottawa Model Smoking Cessation, working with the nurses. The other thing is our nurses in primary care are also trained in spirometry, so they do that early identification. And as Kenny had alluded to earlier, you know, one of our pieces is more on physician engagement and letting them aware of our COPD program and gradually get our uptake. So they're a good fit for, our coordinator's been a really good fit for those 2 programs because they kind of overlap. Now the only other, as far as respiratory therapists, we have 18 respiratory therapists that are involved in INSPIRED, and we are also working on training home care nurses on the INSPIRED program as well. So our COPD coordinator is organizing that through through home care. The other big next steps for us, as far as again, we want to celebrate. We want to start looking at our data, start some preliminary analysis on our data that we've collected to date. We keep building on our successes to date, the COPD pathway in acute care, etc. Anything to add there, Kenny?
No, I think that covers it.
All right, thanks guys. Thanks for your brevity there. We're going to move to Ottawa Hospital, and Wendy and Sherry, I'll just flag for you a question here from Marguerite. What is the education package that you're providing your nursing clinicians with respect to the action plan management?
Okay, I'll address that question at the end, I guess. Plans for moving to full scale. So our goal initially was to enroll 100 patients in 12 months across the Ottawa Hospital. We currently have enrolled 70 patients in 6 months, so we're on our way. Initially, we enrolled patients on the respirology unit only to run some PDSA cycles through that unit, and a very engaged unit with a very supportive respirology team. We've now since moved to the medicine and family medicine units across 2 campuses, which are 8 kilometers apart. That creates a little bit of a logistic challenge on its own, but we're able to manage. Referral system in place. We have a referral system for the CCC rapid response nurses, pulmonary rehab program, community health centers, lung association, as well as the regional palliative consult team. Part of our next steps moving forward, we understand that we've got over 250 patients that did not meet the criteria, and largely those patients are coming from nursing homes or retirement homes. And we do have excellent geriatric outreach nurse practitioners at the Ottawa Hospital, so could we potentially meet with them and build capacity with those nurse practitioners to reach out to the patients in nursing homes. As well, again, building more capacity with the CCAC rapid response nurses as far as providing them with more respiratory education. I think many teams have addressed the primary care point. I think, in speaking with our hospitalists, I understand spirometry is not as easy to access as we had thought it was. So to identify barriers among primary care physicians and potentially provide them the resources where the spirometry testing can be done in the community. As well, palliative care, we don't have a strong palliative care component to our program at this point in time, but we have made some initial contact with the palliative care team in-house as well as the regional palliative consult team. ED, I think that's down the road, as well as I think potentially developing an in-hospital certified respiratory educator program. We have a very successful diabetes educator program at the Ottawa Hospital. So potentially could we look forward to developing something similar to the diabetes program? That was 15 years in the making, but could we potentially go in that direction? Senior management understands the value to that program. To answer the question as far as what is the education package that you're providing your nursing clinicians with respect to action plan, there have been cutbacks with RTs. Initially, RTs, CREs have committed to the INSPIRED program. They're seeing some patients on the respirology unit, however, don't have the capacity to meet the demand on other units. So patients are not receiving the action plans until the home visit. I am doing all of the home visits, provide them with a CTS action plan, as well as there's an excellent chronic obstructive disease circle of care small booklet format that I provide the patients, and it's a picture book, very easy to look through, very easy to read, and basically goes through that kind of the continuum of care in managing COPD. So I do go through that booklet with patients, as well as we give them information on the Breathe Easy booklets on if they're on oxygen, puffers, exercise. We give them that information in a folder as well. Hopefully we've been using the circle of care. Yeah, it's an excellent tool to use with patients. I hopefully I've answered that question.
Fantastic. Thank you so much. And I should mention that Wendy and Sherry actually prepared a few slides that we're going to make available on the hub, so you'll have access to those and some of the detail that they went through in particular on today's call. What we weren't able to get to on today's call is we prepared for you today actually results that have already come through in the midpoint survey. So we're going to these slides are available to you, of course, in English and French, so they will be available to you, and go ahead and have a look through those in terms of what we found in the survey thus far. But really exciting that across the country there's now almost 400 patients that have been enrolled in an INSPIRED-like program as part of this collaborative, and that's all to your credit. It's a huge amount of work that you've done these past few months. I'm going to skip right ahead just to the very last slide. So bear with us for a moment, just because I want to make sure you see some upcoming dates. So we've got a few optional webinars coming up. There's going to be one on telehealth. We're going to hear from the Ontario Telehealth Network, which is just a tremendous resource in Ontario, but will lend insights certainly that are relevant across the country for those of you who are combining telehealth strategies with your INSPIRED approach to care. We also have that Part 2 optional webinar that I mentioned on insourcing innovation, which is really about co-design of care, and also making sense of data alongside patient narrative. June 25th, that's our next INSPIRED webinar. So I'm going to suggest to Claudia Amar, who's on a plane right now heading to Halifax, to the Halifax Roundtable, that we share the midpoint survey results with you at the outset of that webinar. So feel free for all your team members to come to that. And then important to mention actually that we don't have planned webinars until then in September. But we've already heard from the Ontario Roundtable with the 7 teams that came together in Toronto there a couple weeks ago, that there are some areas that you really feel like you could use additional support, some of which we've talked about today. So CFHI does have its homework cut out for us. We are going to be coming back to you with some suggestions around how to have those content webinars and continue to support you, including beyond September when we know the formal collaborative ends. We think there are some great ways that we could continue to have a community practice and have calls like we have today where we prioritize hearing from you and what's working for you. So I want to thank all of our speakers for joining us on today's call. Thanks to Sean, Kathy, Jillian, Graham, and all the speakers from the 4 teams that participated, and then all of you who took time out of your day to spend with us as well. So we appreciate it. Thanks. Have a great day, and we're here should you need any form of follow-up or questions around what you heard today.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.